Well, good afternoon, everybody. I want to warmly welcome you to our special webinar that we're hosting today to recognize the 2020 International Year of the Nurse and the Midwife. And I would like to begin by acknowledging that the land on which the CMNRP office is located, which is in Ottawa, Ontario, and also where I live and work, is the traditional unceded territory of the Algonquin Anishinaabe people. So as you know, the World Health Organization designated 2020 to be the year of the nurse and the midwife to acknowledge the work of nurses and midwives globally, a once-in-a-generation opportunity to put nurses and midwives at the center of global and health policy. The International Year of the Nurse and the Midwife was a time and a year to celebrate the 28 million nurses and 2 million midwives who make up half the global healthcare workforce. Evidence suggests that adequate numbers of well-educated nurses and midwives are vital to tackling the rise in communicable and non-communicable diseases, and that they significantly contribute to reducing morbidity and mortality rates and to reducing adverse health effects and events. And a year ago, we were making plans to celebrate the year of the nurses and midwives. The pandemic quickly turned all of our lives upside down. And our attention was exclusively focused on the pandemic response to keep our communities and our colleagues safe. The courageous work of all healthcare workers in the face of the coronavirus was commendable. And we thank everybody involved in the pandemic response. And not only just healthcare providers, housekeeping staff and administrative leaders, IPAC leaders, unit clerks, everybody. In my 20-year career, I've never seen such rapidly emerging health evidence and changing policies, sometimes within the hour. And what we have lived through is truly incredible, and we will never forget this time. We've had to be so nimble and flexible and oh so adaptable. The extreme dedication has certainly taken its toll, and we know how exhausted so many people are right now, but we thank you for your tireless dedication. We are getting through this. So let's keep being kind to each other and to ourselves. But the reality is the COVID-19 pandemic did not allow us to appropriately recognize this important tribute to nurses and midwives. So today we're having a celebration, and I want to show you this video.
We've been making a film for International Nurses Day to recognise the incredible work of nurses and midwives.
We all have things to be thankful for.
I'm thankful to the nurses who took care of my wife when she was seriously ill in hospital last year.
I'm thankful that nurses and midwives are helping us make progress towards health for all throughout the world.
I'm thankful for the midwives we had when our children were born.
2020 is the International Year of the Nurse and the Midwife.
Currently, the world faces a shortfall of 9 million nurses and midwives.
Millions of people around the world rely on nurses.
There was so much more that could have been said. I was going to talk about how nurses saved my life, twice. But then the COVID-19 pandemic happened and made it impossible for us to continue filming. Now, the message is clearer than ever. We need nurses and midwives now and in the future to ensure access to health for everyone, everywhere. International Nurses Day is the perfect opportunity to say a huge thank you to all the nurses and midwives around the world who work tirelessly, often without thanks, to keep us all safe. It is vital that governments equip nurses and midwives with leadership skills so they can lead and inspire the next generation to save lives. Share your own story and let's say a huge thank you to nurses and midwives around the world.
So I thought that was a very fitting introduction to today's celebration, and we do want to see this as a celebration. We're a little bit late, but here we are today, and I'm absolutely thrilled to be hosting this webinar with my colleague Lauren Rivard. We have a guest, Dr. Danielle Macdonald. The title of her presentation is Celebrating Collaboration Between Nurses and Midwives, the Experiences from Nova Scotia. So Danielle Macdonald is an assistant professor at the School of Nursing, Queen's University, and her research focuses on the experiences of global birthing care. Specifically, she's interested in collaboration, midwifery, respectful maternity care, and person-centered practices. Dr. Macdonald explored how midwives and nurses collaborated in Nova Scotia for her doctoral research. She used feminist post-structuralism and case study. She completed her PhD in 2019 at the University of Ottawa School of Nursing. And Dr. Macdonald has experience teaching nursing in culturally complex contexts, most recently in the Middle East. She is thrilled to be back in Canada and looks forward to creating inclusive relationships to collaborate and learn about the experiences of birthing care. So Danielle, we warmly welcome you today to this webinar.
So first, I just want to say it's a real pleasure to be invited to share this work with all of you. This has certainly been a labor of love of mine and something I'm very passionate about. And I think as Christina had shared, you know, in this 2020, what was supposed to be the year of the nurse and the midwife, it really became the year of the nurse and the midwife in terms of all the work that everybody has been doing to support our communities in light of COVID. So I hope that this brings you some happy reflection as I share this with you. And I really look forward to, you know, hearing your questions towards the end and hearing more about your experiences here. So just to begin, I'd really like to acknowledge that I'm here at Queen's University in Kingston, and it's situated on the traditional Anishinaabe and Haudenosaunee territories. And this is a photograph of one of the parks that I go to regularly here, and I've really enjoyed. I'm new here, so really enjoy the opportunity to see this beautiful part of Canada and learn more about it. And I also think it's really important to acknowledge Mi'kmaq, which is where I'm originally from and where this research took place. So I'd like to acknowledge that part of the world as well. So a little bit about me as we get started. I know Christina provided a lovely bio, but just so that you know a little bit about who I am and what I'm interested in. I, without a doubt, have had a lifelong interest in both midwifery and global birthing care experiences. I was that kid at, you know, 8, 9 years old. If there was a baby anywhere nearby, I was the one that was sitting right beside the mom who was nursing that baby. Or, you know, into my teen years, I was seeking out any opportunity to babysit babies as small and young as possible, and to ask all the questions as a teenager that maybe I didn't know to ask as a little kid, and that has just fueled my passion for all of this into now, and it hasn't left me. It's always stayed with me. So definitely very interested in these things. I am a registered nurse. I definitely would identify myself as a midwifery advocate. I feel very strongly and believe very strongly in the values and principles of our colleagues, midwives, and likewise collaboration and looking for ways that we can collaborate and support each other in our professions. I think that's really important. I would also say I'm a feminist, and gender rights, women's rights, the rights of birthing people, the rights, you know, we think about nurses and midwives both being historically female-dominated professions. That's really important to me as well. I'm Nova Scotian. As Christina said, I completed my PhD in 2019 at the University of Ottawa, and I joined Queen's University School of Nursing in September of 2020. So I'm new to Kingston and new to Queen's, and really excited to learn all of the contextual factors of these things here in Ontario. There we go. So we have 3 questions that we would love for you to participate in, and we have a poll feature. So what I'll do is I'll show you the 3 questions on here, and then they're going to come up as one section on the poll feature. And we'd love it if you would answer the questions, and then we'll sort of reveal them to everybody so we get a little sense of who's here and where everyone's from, and why you came to this presentation. So I'll just let you have a look at these. And then the final one. Okay, Christina, if you want to set up the poll. Let's see, give everyone a couple of minutes to do this so you can answer each one.
I've launched the poll. Everyone's seeing that okay?
Yep.
And so once you've finished answering the 3 questions, you push submit, and that will make your entry. So far we have about a third of the group.
Oh, great.
And now we're at about half.
Perfect.
I think everyone's pros now using Zoom.
Had lots of practice.
We've had a little bit of practice, yeah. So there's perhaps 5 people, and we'll just see if they're in a place where they can answer these questions. We'll just give it another few seconds.
Sure.
Okay, I think this is probably what we have right now. So I'm going to push end polling, and then we can share the results here.
Okay, so we've got most folks from the east. Oh, we've got a couple from outside of Ontario. Very nice.
Yeah, we have 3.
3, okay. Well, welcome. Welcome to everyone, but welcome to those outside of Ontario. That's lovely. So most people are here. They want to know about collaboration between midwives and nurses. Inspired, nice. Okay, curious to see, yeah, what it's like in Nova Scotia. Perfect. Oh, great. And then we've got, okay, so we've got almost equal midwife and nurses, and some decision makers, and then some clients and other healthcare providers. Well, that sounds like a really lovely sort of robust group of people, well representing where we are. So that's great. Thanks everyone for participating. It just helps us to sort of know who's here and you know, include everyone. So these are the objectives for today. Hoping that we'll be able to identify how collaboration between midwives and nurses has been sustained in Nova Scotia. We want to recognize that institutional, historical, and social discourses are influencing how midwives and nurses collaborate, and then sort of explore how collaboration between midwives and nurses may lead to innovative and sustainable approaches to birthing care. So just to give you a little bit of background, and for the midwives and nurses, I know you may know a lot of this already, but just to bring everybody together, we know that midwifery and perinatal nursing are not equitably distributed around the world. So we can look at the state of the world nursing report and midwifery reports that are coming out. We know that there are shortages in both of these professions, and that not everybody has access to the care from these providers that they want to have and should have. We also know that the first province to regulate midwifery in Canada was here in Ontario, and that legislation took effect in 1993. So in many ways, Ontario has really been the pioneer in terms of midwifery regulation, integration, implementation, and education. Midwifery is provincially regulated in Canada. So this has led to a number of different practice arrangements, and not just practice arrangements, but models of care, ways of working, financial compensation, and the systems and structures that surround all of that. And so there's a lot of similarity, but there are also a lot of opportunities to learn from each other in how some of those things are different and what is working in different places. We also know that the integration of midwifery into those existing perinatal services over the last 30 or so years has not always been a smooth process, and certainly within the Nova Scotia context, I can say that is accurate. When we look at nurses and midwives, we know that when we look at the literature there, we can trace these historical tensions between the two professions, and we can see that at a global level and also here in Canada. And a lot of that has to do with this overlap, this sort of history of overlapping roles and skills and identities. So, you know, we think about nurses, midwives, nurse midwives, how people how those professions are defined, what those roles are, what the skills are, who does what, and the variations in those dependent on where you are in different countries and in different parts of the country in Canada. So we know that those tensions have been fueled by, some uncertainties and some certainties within those role skills and identities. I did a Joanna Briggs Institute systematic review. I looked at qualitative literature for my master's. And when I did that, I wanted to know, what was out there in the literature in terms of how midwives and nurses collaborated. And what came out of that, we found that there were only 5 studies about that. And of those 5 studies, there were 3 that were Canadian studies. And really what we found was that what we need is more research, and we need to know more about what that collaboration between midwives and nurses looks like and what those experiences are. So when we talk about midwifery in Nova Scotia, it's important to know that midwifery was regulated in Nova Scotia in 2009. So that's quite a bit later than it was in Ontario. And certainly, it's only been 12 years this year since midwifery has been regulated there, which means that, it's had the benefit of being able to look at other provinces and to learn from what has worked with other provinces. But it also means that there aren't as many, I guess it just hasn't had the time to flourish and grow and integrate and percolate the way that it has in other places. At the time of the study, there were 7 practicing midwives. Currently, I was just talking to a midwife friend in Nova Scotia the other day because I thought I better have some current information for you as well. So right now in Nova Scotia, we have there are 17 midwives who are filling 16 full-time midwifery positions. So there are 8 at the Halifax at the IWK. There's 8 positions, 9 midwives are filling them. And then there are 4 each at the 2 other rural sites. So one in the South Shore and one in Antigonish. All 3 sites are currently active, but it's really important to know that at the time of the research, one of the sites was actually suspended. So of those sites, 2 of them are rural and 1 is urban. The registered midwives are licensed by the Midwifery Regulatory Council of Nova Scotia, and they do have an association which was founded in 1992. And with only 3 model sites offering midwifery in the province, we see great inequity in the distribution of access to midwifery services in Nova Scotia. There are often very long wait lists. There are people that are traveling from other jurisdictions to these areas to access midwifery care, but it really has not expanded beyond those 3 model sites that were set up at the time that midwifery was integrated. In terms of perinatal nursing in Nova Scotia, we have the benefit of having had a long-standing presence within the healthcare system, and that's across Canada. And so in Nova Scotia, we have registered nurses who are providing perinatal care in antenatal, intrapartum, and postpartum units in hospitals and public health as well. We also have registered nurses who are attending home births as second attendants at those 3 model site regions. And that has been a very interesting development and something that has come to be quite welcomed amongst the nurses and midwives themselves. But it was really the reason for establishing that opportunity was really to build some capacity and being able to continue offering home births as a service to the clients in those areas. And the College of Registered Nurses of Nova Scotia, it's now the Association of Nova Scotia, I'm going to get it wrong, the Nova Scotia College of Nurses. They've changed their name now, but prior to this, at the time of the study, they had 2 position statements. So they had one on midwifery and one about second attendance at home births to really clearly ensure that there were clear expectations and understandings around the roles of nurses as they worked with midwives in these roles. So the study purpose for this doctoral work was really to explore collaboration between midwives and nurses, specifically in Nova Scotia. And I was really interested in knowing how midwives and nurses collaborate as they're providing this perinatal health care in Nova Scotia. So these were some of the issues that we were interested in looking at as we sort of delved into, and this really informed the interview guide. But we wanted to know what the meaning of collaboration was for the midwives and nurses who were working together. We wanted to know how the midwives collaborated with nurses, how the nurses collaborated with the midwives. I also talked to service users, which were mothers, and wanted to know what their perspectives of collaboration was. What were their experiences of midwives and nurses collaborating? Also, what were the administrative stakeholders and other care providers? What did they see? What were their perspectives on the collaboration between midwives and nurses? And then really, because I think this is such a contextually specific thing to look at, given the sort of shared and tension-filled history, how do the social, historical, and institutional discourses influence collaboration between midwives and nurses? So I used feminist post-structuralism as a theoretical perspective to really explore this. And with the feminism really brought that critique and challenge to the gender inequalities and inequities, and sort of provided that ability to advocate and look for where gender equity and equality was happening and where it wasn't. The post-structuralist piece really allowed me to look at the power relations. So when we're looking at collaboration, what did those power relations look like? What were the discourses that were influencing how folks were collaborating? And what language were they using to tell me about that? And then, you know, other important concepts were things like governmentality and subjectivity and subject position. So who were the people that were, you know, what were their subject positions? Where were they coming from? But also this idea of governmentality. So how were their practices or their beliefs or their values governed? Not by the government, but by, could be discourses or the institutions in which they worked. And then together, really what feminist post-structuralism allowed me to do was to attend to the role that gender has in those power relations and how those dominant discourses have been shaped through the language that we use to describe them. So it was a case study. It was an instrumental case study based on Stake's work, and it really, this was an appropriate methodology for this because I was really interested in the how piece of this and the why. So how were they working together, and why? What were the things that were contributing to this? You know, especially those discourses, that historical, contextual piece. It was context specific, so it was specific to Nova Scotia. I'm not saying that this is applicable in all jurisdictions across Canada, but it was very specific to Nova Scotia, and using case study allowed us to really develop a really deep understanding of what was going on. And then there was this concept of binding the case. So the binding of the case, really what it does is it puts a boundary around the case so that you stay focused on what you're looking at. So for this, that case was the geography of Nova Scotia. So I was interested in Nova Scotia, which allowed me to look at those 3 sites. So a little bit about the setting itself. So as I said before, there were and still are 3 model midwifery sites in Nova Scotia. And as I said before, one of those model sites was suspended from January until August 2018. So that was, I started to do recruitment for participants in February of 2018. So that was a month before I started, and I was quite concerned about it. And so that was one challenge, certainly, that I faced. It's also important to know that at the time that this was happening, the province was bringing together, had just come under one health authority. So they had taken regional boards and brought it into one health authority. And then the IWK Health Center, which is I'm sure many of you guys are familiar with, is our tertiary level maternity and pediatric hospital in Halifax. That is a standalone from the health authority, but really they work very closely. At the time, there were 9 midwifery positions, and with that suspension of 1, there were 7 practicing midwives at the time that the data was collected. It's also important to know that we had the registered nurses trained as second attendants for home births at all 3 of the sites. But at the time of the study, only the IWK had nurses that were actually attending home births. And so the other piece to this that's important to know as well is that all midwife attended hospital births are attended by a midwife and a registered nurse. So when that midwifery client comes in, they are assigned a registered nurse for labor and delivery. And then when they are transferred to the postpartum unit, they would be also assigned a registered nurse there. So in terms of the data collection, I used purposeful and snowball sampling. So really I wanted to target that specific type of participant. And then I really encouraged those participants who I interviewed to share study information with others that they thought might meet the criteria to participate. I had two types of data sources. So the primary sources were the interviews. They were face-to-face, they were semi-structured, and they all occurred in private locations. They lasted 30 to 90 minutes, and all the participants signed consent forms. And then I had secondary sources. So that included the documents, and those documents, there were 24 in total. And one of those documents was a policy report. A second document was, one document was a policy, a second document was a report, and the third, everything else came from media reports of things that I found in newspapers and online, that sort of thing. And then I had field notes, and then I also had two individual discussions, so discussions with two individuals separately, and then a group discussion. And that was really in keeping with sharing the preliminary findings with the participants, giving them an opportunity to come back together as a means to be engaged in a feminist principle of research. So including the participants, building trust with them in the hopes that we can continue to do research together and that it's with them and collaborative. I used feminist post-structuralist discourse analysis for this. And I won't go into great depth about sort of what this is. It's funny, I have this presented to you in a chart, and it's actually more circular than that. But just for ease of being able to see how this all works, essentially, you know, it's looking at each of the transcripts and identifying the issue and then breaking it down into beliefs, values, practices, and discourses, taking those issues that are similar and creating sub-themes, and then again, taking those similar sub-themes or different, similar sub-themes and then building those themes. Happy to talk to anybody about this at greater length, but I think you're probably more interested in the findings at this point. Okay, so in terms of the participants, I had a total of 17 participants. So almost equal midwives and nurses participated. We had 3 mothers that participated, 1 care provider, sort of colleague, and then 3 stakeholders / decision makers. Now, when you do the math, you'll see it doesn't work out. And that is because one of the participants withdrew after completing her interview. She was a mother participant. She actually realized that she had been attended by 2 midwives, not by a midwife and a nurse at her home birth. So we had to take that out, unfortunately, because it was a great interview. I had ethical approval from the University of Ottawa, from the Nova Scotia Health Authority, and from the IWK Health Centre. And that was all, those approvals were all in place before I approached the participants. Okay, so this is the exciting stuff. So these are the findings. I had 4 main themes, and I think there's 11 sub-themes is what it totals in the end. And I'll go through each of the main themes and sort of give you a bit of an overview. I could certainly talk about this for days, so I'm cognizant of the time. So I've just sort of done a high-level overview. But just to let you know, it was really interesting to see this come through, and it was really fun. I'm going to say fun because it was to look through this and to see what was happening. So the main themes were negotiating roles and practices. So this idea of every nurse is different, every midwife is different, every birth is different. The second one was about sustaining relationships. So this idea that the more we can just build relationships with one another, that was really important. The third main theme was this idea of reconciling systemic tension. So this whole kind of getting back to that historical piece of these tensions of, you know, this medical model versus and the midwifery model. And then the final main theme was moving forward, a modern model for nurses and midwives working together. So we'll go into them. So what I've done is I don't have quotations for all of them because most of the quotations are fairly lengthy. And if you're really interested, you could always look for my dissertation and sort of go through those. But for today, the three sub-themes that were related, the three sub-themes that were related to the negotiating roles and practices were a constant negotiation of roles, a crossover of skills and practices, and communication and good anticipating. So with the constant negotiation of roles, the midwives and nurses were talking about how they were always negotiating the roles, what their roles were. And that changed depending on the context, so whether it was home or hospital, and it changed depending on what the client's needs were, what the relationships were like between the midwife and the nurse and the client, and between each other and amongst each other. But there was generally an openness to this negotiation. So it wasn't necessarily fueled in a tension-filled way, but that was an ongoing thing. And the crossover of skills and practices, I'm going to read Chelsea's quote. She was a midwife and she said, it really does cross over quite a bit. The skill set, like the actual clinical skill set, as well as the supportive care piece, because typically nurses are doing all the supportive care until a doctor comes in and catches the baby. So with midwives, because we're there once the client is established in her active labor, some nurses really enjoy that supportive care piece, and they aren't sure then what their role is. So I always do try to have a chat with a nurse as we're getting settled in and say, like, you do what you do and I'll just follow your vibe and my client's vibe. I'll kind of work around you all. So still recognizing, the primary care provider and the midwife and the nurse that's there as well, but having that, recognizing that crossover can work for both, and being open to that crossover, not seeing that as something to be guarding. And then communication and good anticipating. So all the participants talked about this, that they really worked hard to communicate. And the midwives talked a lot about the nurses and their ability to anticipate and how that really impacted their ability to provide care, because they could see what was happening and be supportive. The second main theme was sustaining relationships. And so the three sub-themes were testing trust. If they did not trust us, they would not sign up. Midwives depending on nurses, we could not do our job without them. And needing more opportunities together. They're not the unknown anymore. So with testing trust, that was an interesting finding, because the participants were talking about, some of them had been there since midwifery had first been implemented, and they'd seen a change, both midwives and nurses, in the practices and being able to trust. But it was almost, I can remember one nurse talking about not necessarily trusting the midwives at first, but once she had worked with them over time, she came to understand what they did and trusted that what they were doing was evidence-informed care, and that they had the same goals at the end. And then this idea of, if they didn't trust us, they wouldn't sign up, that really related to, the nurses who signed up to be registered nurse second attendants for home births. The ones that wanted to sign up were the ones that trusted the midwives implicitly, which is not to say the others didn't, but they were really there to work with them. Midwives talked about depending on the nurses. And so gave examples about, how the nurses supported them to provide care. If they had a precipitous birth arriving at the hospital, the nurses could care for that individual until the midwife got there, and that the midwives were trusting the nurses to know sort of how they worked and to support that approach to care. And then the needing more opportunities together. This is one of my favorites. And so this idea that they are not the unknown anymore. So this was Bridget, and she was a nurse, and she said, I can tell you things that I think have strengthened it here. It's the More OB program, learning together, not just going to a midwifery course or going to a course on nursing or going to a course on physician skills. It's we all sit down at the same classroom and we all learn the same stuff. I think that was huge for collaboration. And I think being in the same facility, working closely in the same unit together makes a huge difference. I think that's a huge strength. And I think playing together, doing social things outside work, that was really important as well. And what I can say is what I found with most of the participants, there was a thirst to have more opportunities to work and play together. So then we look at the third theme and main theme, and we see reconciling systemic tensions. And this was a really interesting theme. So there were 3 sub-themes associated with this. The first one was the invisibility of collaboration and the quote unquote best kept secret. The second was resisting and accepting institutional expectations. And then the final one was this idea of the medical approach versus the midwifery approach. I found the first sub-theme really interesting. So this was Florence talking about this invisibility piece of their collaboration. And Florence was a midwife, and she said, because the best kept secret, and she says, and we all chat about it, is that when you have a birth and a nurse and a midwife in a room at the hospital, it's easy because we clean up with them. Like, we're all doing the same thing. There's so much overlap in our roles that we're taking a huge burden off of them with a client that isn't epiduralized usually, and would be a lot of work. And then they're taking a huge burden for us. So there was this sense of anything protecting that collaboration and maybe not making it as visible to outsiders in the concern that if folks really knew how much collaboration was happening and how it really was not only enjoyable, but helpful for both providers, that somehow that might be changed or taken away. There was participants definitely talked about how different examples of how they resisted and accepted institutional expectations of their roles, of their professions, of the policies, and there were various examples of both. And then finally, and I don't think this is a surprise really, but this whole the medical approach versus the midwifery approach. So that has been a very historically dichotomized experience for nurses and midwives, and that was certainly shared as well in Nova Scotia. And then finally, the fourth main theme was this a modern model, moving forward, a modern model for nurses and midwives working together. And this one I was really excited about because as you can see, there were 2 sub-themes. The first one was the birthing culture has changed, and the second was allies and advocates. And I've actually included quotations for both because I think this is the hopeful part in all of this. I think all of it is great, but this is sort of the piece. So for the first one, this was Daisy. She was a nurse, and she had worked in various perinatal capacities in nursing. And she said, well, I think it's a modern midwifery model if we can have nurses collaborating with midwives and working, like, why can't a nurse go work at the midwifery clinic with them and work with them in their office and see patients? Like, we should be doing things like that. I think if we can just change the way that the whole model of care, like, that would be ideal. But yeah, I think like we should be working with them and having a modern model for nurses and midwives working together. The participants I talked to talked about this. They talked about wanting to work together, and they talked about how the experiences that they have had and worked hard to have, because it hasn't been easy, is starting to change the birthing culture, and it's influencing visions of what perinatal care could be. And then the allies and advocates was interesting. Elizabeth was a midwife, and she said, she's talking about nurses, and she said, I mean, they can promote midwifery. I mean, that's what I think they can still talk about it. They can promote us. But she was conflicted because she said, on the other hand, we can't meet the demand. So it's a little bit obvious, but definitely support us. And as I said, like, hoping to have an influence on culture, spreading the word and supporting this idea of midwifery and working together. So this leads to a bit of a discussion, and really there were sort of 4 elements to the discussion of these themes that stood out, and they were the sustainability of midwifery, midwives, nurses, and hegemonic medical discourses, person-centered cultures, and a new collaborative model of care. So we really focused on the dominant discourses that were influencing these experiences of nurses and midwives in Nova Scotia. And, we can see a lot of these are not unfamiliar to folks today, I think, who who are at this session. So when we're looking at sustainability of midwifery, we know that sustainable midwifery is an issue in Canada and around the world. And so in Canada, we know that researchers in Alberta and British Columbia, they reported that 64% of midwives surveyed had considered leaving midwifery within the last year. That was 2018. And in Manitoba, researchers describe midwifery as a quote unquote precarious profession due to the lack of professional capacity. So the retention and recruitment challenges and the high demands on a profession that has small numbers. And these are global trends. I mean, these are specific to Canada, but they are global trends. And these challenges really offer us opportunities to be innovative. You know, we can look at Australia. They have dual licensure for nursing and midwifery in rural and remote areas. And the United Kingdom has dedicated home birth teams with midwives and midwifery support workers to increase access to home birth. We also look at this historical dichotomy between medical and midwifery discourses, which is not new to any of us, but it really has created to sustaining these silos of healthcare providers, and it's actually impeded collaboration. Nurses have really been positioned within this historical pattern of an alliance with physicians. And midwives or midwifery and nursing, I mean, they're both female-dominated professions. The difference being that nursing was accepted into the healthcare system and that medical discourse. And of course, midwifery has been excluded from both up until more recently. We can also talk about this invisibility of collaboration that we saw between these midwives and nurses in this study and how that may reflect this historical tendency toward invisibility and marginalization of midwifery. In terms of person-centered care, that's defined by values of respect for persons, individual right to self-determination, mutual respect and understanding, and it's enabled by cultures of empowerment. So this idea of person-centered care really embraces woman-centered, family-centered, and patient-centered approaches. And the experiences of collaboration between midwives and nurses that the participants described in this study really illustrated their ability to create person-centered moments and hours and spaces. And it really positioned midwives and nurses in Nova Scotia as exemplars for person-centeredness. And then finally, evidence supports midwife-led models of care. We know that the literature has demonstrated that time and again, and putting midwives as the lead or the in-charge healthcare provider. So a collaborative model of care with midwives as lead in the primary care provider role and nurses in that nursing role alongside them really should be explored based on the experiences of these participants. I mean, the Canadian Association of Midwives has called for collaborative and innovative approaches to midwifery care, and the findings from this study really illustrate how nurses have become and have the potential to be cross-pollinators of midwifery values and practices, helping to change some of those mainstream medical discourses. So, recommendations. So what came out of this? We need to explore collaboration between midwives and nurses in other jurisdictions in Canada. What's really interesting about Canada is that we have nurses and midwives working alongside each other in different contexts and different places. And that's different compared to many other countries where it would be a midwife or a nurse midwife that takes care of all of the perinatal care, and nurses would be working in other areas. So this is a great opportunity for us in Canada. We need to explore how working with midwives is changing nursing beliefs, values, and practices, not just nursing, but also medicine. How have the midwives impacted and working with them? How is that changing what we're doing in perinatal care? We need to explore the feasibility of a midwife-led and nurse-supported model of low-risk perinatal care. We need to raise the public profile of midwifery, home birth, and for collaboration between midwives and nurses amongst the public, but we also need to raise this amongst our healthcare providers. We need to create educational pathways between nursing education and midwifery education to ease entry from one profession to the other. One of the things I've heard anecdotally from many nurses is how much they would love to be midwives, but the education route to do that is very difficult and in terms of being able to acknowledge or embrace the experiences that they may already have that could contribute to their knowledge. And we need to create more opportunities for midwives and nurses to build professional relationships. That was underscored throughout the study, how much the midwives and nurses in Nova Scotia wanted those opportunities. So what could this mean for Ontario? Well, I'm really interested in continuing with this work. And so I'd really like to know how midwives and nurses are collaborating here. I'd like to know what's working, what isn't working, what would people like to see happen. How can we support collaboration between midwives and nurses here? So what can we put in place to support those opportunities and ways to collaborate? We can look at how is collaboration with midwives changing the beliefs, practices, and values here in perinatal care in Ontario. And we can explore what the feasibility of a midwife-led, nurse-supported, low-risk model of perinatal care could look like. And again, just to echo what I said before, how could we create educational pathways between nursing and midwifery education? So just to wrap up, ultimately, this idea of collaboration, which for many of you who are here today, you already know this, it's very complex. There are many factors, there are many things that influence the way that we collaborate with our coworkers, and that certainly wasn't different. It's very similar for midwives and nurses in Nova Scotia. What's interesting about this study is that the findings really illustrated that collaboration was mostly working well in Nova Scotia, even though it faced many systemic challenges. And that was different from what the literature had said before, which was actually sort of painting a picture that it was not necessarily working very well. I think what this study also does is it provides us a positive example of birthing care, something that works and gives us the hope that we can, in challenging circumstances, work together to build sustainable midwifery services in Nova Scotia, but also perinatal services in other jurisdictions. And I think it also highly illustrates the great potential for building collaborative teams of midwives and nurses in Nova Scotia and in Canada. So I'd like to thank you all for your attention today. It's been really, I'm really happy to share this with you. Certainly, if you would like to reach out with any questions or if you'd like to connect, please email me. I'm new here. I'm looking to hear and make connections and as I move forward with this work. I also just want to say, and that's why it's very small in the bottom corner on your screen, the first manuscript from this research is currently in press. And so it is there. You can track it down, but it hasn't been totally published yet. It is accessible, I think, in the journal. So you can check that out if you'd like to read a little more in depth about this. That's great. So thank you very much. So Christine, I think we have one more question to put back to everyone.
Yeah, for sure. So we have a Mentimeter question for everybody. Lauren's going to pop a link in the chat, so you could click on the link or you can use your smartphone and enter www.menti.com. And the code is written in the chat box, and I'm going to share my screen right now.
Oh, here, I'll stop there.
Okay, here we go. And so this is the question that Danielle is wanting to ask. Reflecting about the findings presented today, how could collaboration between midwives and nurses be strengthened in your organization or in Ontario? So as you join that Mentimeter, you basically have open text, a commenting ability. And when you push submit, those comments are going to start flying up on the screen. So we'll give people a few minutes to connect to menti.com. I know it is a couple steps for people if you don't already have the app uploaded on your phone. Lauren, can we turn to the Q&A box? Because what questions do we have for Danielle that she could answer right now?
Yeah, absolutely. So first off, I would just like to say thank you so much for your presentation, Danielle. It was really, really wonderful to hear about the collaboration happening in Nova Scotia and that the trajectory seems to be on the upward slope for the province, which is really wonderful. I'd also like to say congratulations on your manuscript as well. So looking forward to getting my hands on that and taking a look. So we do have a few questions in the chat box, and I'm just going to go in the order that they've been posed. So the first question is from Paula Archambault, and it says she's curious about who employs the nurses who attend home births as a second attendant.
So this is really interesting. I wish that I wish we had some more. I could tell you more than what I'm about to tell you. So those nurses that are the registered attendants for home births. They are employees of the institutions of the hospitals, and they. And I won't get it all right, so I'm not going to give you all the details, but I can find them for you. Please reach out to me for more. But essentially, they do the second attendant role for home births usually in addition to what they would be scheduled for their shifts in hospital. Those nurses have typically been labor and delivery nurses who've had quite a bit of experience. And there is a hiring process for that includes, I think, the lead midwife and other decision makers to identify the individuals that will work and fit best with that home birth. But yeah, the employer is still the institution, and it's interesting because what happens is they do go on call and they get a very small, and I can't tell you the amount, but they do get a small amount for being on call. It's not very much. And then if they actually get called out, then they'll get paid whatever that rate is, which I do know, and I can't speak to it at length, but I do know, there have been some challenges in making that equitable for midwives who spend most of their lives on call, and for whom may not be compensated in a similar fashion. So I leave that as an open discussion, but the short of it is it's the employers are the hospitals.
Thank you very much. And we will pop, just so everyone knows, in case you want to reach back out, we'll pop Danielle's email into the chat as well for everyone. So our next question is, in hospital births, was an RN present throughout the entire length of labor or just the time of birth and early transition? So the question was prompted by the first quote in your, I think it was your first theme, around Chelsea, the midwife statement.
That's a great question. So it's in Nova Scotia at the hospitals, it's the same as if you have a midwife as your primary care provider. Client comes into hospital and they'll usually go to early assessment, but they get assigned a nurse, and that nurse is with them from the time that they are admitted into the birth unit or the labor and delivery unit. And then depending on where they are, what stage they're in their labor, depending on what they've discussed previously with their midwife, depending on if that midwife is called out to another birth. Sometimes that nurse might labor sit for a period of time until the midwife gets there. That particularly would happen if the midwife is at another birth or finishing up or something like that, or if mom is in an earlier part of her labor but has been admitted. So this is the interesting thing about all of this, is that we have nurses and midwives that are working together during labor. So it's what's different for the nurses is that that's different from working with physicians who come in at the end and catch the baby and do what they need to do, and then they leave, and then the nurse is kind of there doing all the other stuff around that, all that supportive care. And so we have a primary care provider who's providing supportive care alongside the nurse. And so initially that was challenging in terms of who does what, and trying to figure out, well, I do that as the nurse, and when you're not here, I'm perfectly capable. And then sort of getting to this place of being able to negotiate that based on the needs of what's going on. Or maybe the unit is really busy and the nurse, generally would be one-to-one once mom's in active labor, but maybe they are helping other things, and the midwives are able to labor sit themselves. So I think that answers that question.
Yeah, I think so. I think that was a great answer, actually. So our next question is, I wonder if you could speak a little bit more to the systemic challenges to collaboration between nurses and midwives in Nova Scotia, and whether or not you see the same challenges in Ontario.
Okay, so I'm going to be honest and say I'm learning about Ontario. So I'm not going to answer the second piece, and that's what I'm hoping that today maybe those of you with your experiences will reach out to me and we can start talking about that, because I don't want to make any assumptions here. other than to say that those systemic challenges have really been around, I think, what the model was before midwives joined, and sort of establishing midwives as primary care providers, not as nurses. And so that distinction of what is expected of a primary care provider versus, you know, a nurse, which is not a primary care provider. And so some of those systemic challenges, I mean, one of the biggest things is that we have 3 of the original model sites. That's it. There have not been any expansions. We've expanded the number of midwives, but we haven't expanded. There's been no political commitment to expanding midwifery services throughout the province. There's been no commitment to that, or even sort of vision for that beyond those who are working hard to do that work themselves. And so I think that's probably the biggest challenge that I can speak to, that I see sort of in a broad sense in Nova Scotia. And then in terms of them collaborating, what I can say is I worked in postpartum care in another part of Nova Scotia where there are not midwives, where there was a history of having midwifery prior to regulation. And so in that jurisdiction, I'm not sure how many, but obstetricians do, I think they're doing all of the care now. And it will be very difficult to move midwifery into that area, yet it's a rural area and folks know what midwifery is there and are looking for it and are asking for it. So I think the biggest systemic challenge to midwifery generally, but also this collaboration piece, is some of those long-standing assumptions, those historical assumptions that have been formed by past experiences prior to regulation.
Thank you. So our next question is a follow-up to the first question, which is in regards to the model, like the actual model. So that it's a question about whether midwives are employees of the hospital within Nova Scotia.
Yes.
So they are, okay.
Yeah.
So here in Ontario, they're independent practitioners, which is a very different model.
Very different. Yeah, so they are employees of the Nova Scotia Health. Okay. I do see a note, and I think it's from a colleague actually who's just correcting me on the funding for the second attendant for the nurses. So thank you for chipping in. And I just see that there's separate funding for the second attendant program. So the registered nurse works for the health authority of the hospital, but the remuneration for being a second attendant is additional to the regular salary. So that's a better articulation of what I was saying before. So thank you, colleague.
Thank you.
For clarifying and correcting me. I was hoping that colleague might be here and might chime in. So that's great.
Wonderful. Thank you so much. So we'll just, I was thinking it was a question, I hadn't read through it yet, but that's wonderful. So the next question is whether or not there are any Indigenous midwives in Nova Scotia.
So that's a really great question, and I appreciate that because it's something I think a lot about. I know that there is movement to support Indigenous midwifery in terms of actually practicing Indigenous midwives, not that I am aware of. But I will say that with a caveat that what I'm sharing with you could be a result of my own ignorance. And so I to my knowledge, no. But I do know that there are initiatives to support Indigenous midwifery in the East Coast. So that is very exciting, and certainly really hope to see some forward motion there.
Wonderful. So we actually are done with the questions. We have one comment from a colleague in Nova Scotia. So it's from Leanne Lozon, and she says, "Hi from Nova Scotia, Danielle. Thank you for your presentation and representation of the journey."
Hi, Leanne.
So, and I believe that we're going to reshare the Menti now that we have more information. People have had a chance to put some comments in.
Oh.
Yeah, so a couple people, Danielle, are going to be following up with you. So I did put your email in the chat box there. We do have a comment here: understanding of scope of practice and provision of care, reducing the silo nature of nursing and midwifery, reducing fear of supporting each other. So this is how we can strengthen. Another person said, I like the idea of creating more opportunities to build professional opportunities as opposed to feeling like it has to be social. And then a comment, I feel there's a lack of nursing understanding and support for informed choice. For example, I feel that more education could help nurses understand that midwives support informed choice, person-centered care, and not what is the preference of the hospital or the MD. So we had 5 questions there. But I think it's a good question to reflect on. This research that you've done, certainly with exploring the context in Nova Scotia. But I think it really stimulates our thinking about how do we collaborate with each other, and in our healthcare system, what are those opportunities to really provide the very best care, and how can we think outside of the box. So for me, it was really exciting when I heard Danielle's research and understanding that nurses could have a role as a second at a birth, and I had never really heard of that before. So I think we can learn many things from our colleagues across the country and here within the province and within the region. So Danielle, we are so fortunate to have you here within our region. You're in Kingston, but so is Lauren at the Kingston office.
So excited to have you here.
Yeah, we're just to have you in Ontario, and I know you're very keen to have conversations with interprofessional colleagues about how we can really maximize perinatal care for families. I mean, I think that's so important for you. So we just really wish you great success as you develop your research program at Queen's, and we look forward to further connections and collaborations with you. So thanks so much for your time.
Thank you, Christina and Lauren and the rest of the CMNRP team for this invitation. It's been delightful. And I seriously sort of have an open email policy. I would say an open door, but in COVID, that doesn't really work. So please, if there's anything you'd like to talk about, and certainly I honor confidentiality and all of those things, wear my nursing hat. So, but I'm really, I feel very fortunate and blessed to be here. Really happy to connect with everyone here. And I look forward to doing more in the future. So reach out with any questions or ideas. I'm really open to that. So thanks again for this invitation. It was really fun.
Really fun. And we thank everybody who attended today, and a few of your colleagues may not have attended. We are recording the session. We'll post it to the YouTube channel, and it'll be on our website. So Ariane will send that communication out when that's ready. And so yeah, if we could all see each other and use the celebration reaction button, I feel like this was hopefully a very nice way to acknowledge the 2020 year of the Nurse and the Midwife. There was other things that we were wanting to do together, but I feel like we're so fortunate with Danielle and the very positive message of strengthening collaboration. So thank you to everybody, and have a great afternoon. Clapping, yeah.